All right, aloha. Now let's talk about combination of brain. It's kind of different brain drugs. So we've got our anticonvulsants, which are going to be for seizures, anti-Parkinson's, and anti-Alzheimer's disease. So because these all have to do with the brain, we're affecting the central nervous system, the pharmacology. So what makes these drugs different than other things that we've been talking about? And mainly it's crossing that blood-brain barrier because we're wanting to get into the brain to affect things going on in the brain that are then happening in the body. So crossing that blood-brain barrier. So usually it has to be either lipid soluble to cross that blood-brain barrier or have some type of ionized or polarized drug that can then cross, or some kind of transport system where it can get through these tight junctions. And know also that the brain will adapt to chronic medication use of these. So that central nervous system pharmacology, again, talking about this blood-brain barrier. So there's capillaries in the brain, these tight junctions, and it's a protective mechanism, right? Because the brain needs to be protected at all costs from toxins and anything that's going to affect us, because not only is the brain our thinking, but the brain affects out to our bodies. It connects and sends signals, and it's our hard drive essentially of information. And so it's the body has really protected it. And so to get the drugs into the brain, there's several things about it to get it to work. So it needs to be either lipid soluble or have specific transporter proteins to get into the brain. And then it'll alter the neurotransmitter function in a couple ways, which we'll talk about. So how do these drugs affect the brain? So we know that the neurons are those functional units. The drugs affect the communication at that synapse, which is that communication point. So it can do it a couple different ways. It either results in an excitatory signaling or inhibitory. So sometimes the brain needs to be like, okay, come on, we gotta excite you, get you going. And other times the brain's like super excited and we need to calm it down. So depending on the condition and what we want to do, we're either exciting it, speeding it up, or we're slowing it down, depending on the condition. And then some of these drugs can be specific for certain neurotransmitters in the brain. We'll get into that into the psych meds with depression and anxiety and things like that. And then neurons adapt receptor expression to long-term treatment. So that's going to be the big theme for today's lecture on these, specifically Alzheimer's and Parkinson's disease and these meds. So again, they modulate the neurotransmitter release, or they can modulate neurotransmitter clearance from the synaptic cleft, or they can modulate the effects of the neurotransmitter postsynaptically. So again, a few ways that, so not only can it excite or inhibit, but it also can affect the neurotransmitters in that whole process of you have your synapses, and whether it's trying to get more in, clearing that stuff out, or something happening on the other end. So here's a schematic of the neurotransmitters. Here's that in between the synapses here. So here's the little stuff coming out, and either it can clear all this stuff out, it can help it back over here, or up in here. So there's different ways that these drugs can affect what you want it to do. So here we've got our neurotransmitters that we generally talk about for the conditions we're going to talk about today, which is seizures, Alzheimer's, and Parkinson's. So acetylcholine, we're familiar with acetylcholine. We've talked about this before. We have within acetylcholine the nicotinic, going back to that tobacco leaf, which we have all through our body, and these muscarinic receptors. And these can be inhibitory or excitatory. Then we've got dopamine, inhibitory or excitatory. Norepi, which we've talked about again with the adrenergics, the adrenals, the sympathetic, and then serotonin, which we haven't gotten into much yet. That'll be the psych meds. Okay, so we've got our anticonvulsants. So anticonvulsant meds, what are they doing? They're stopping convulsions. So what would we use that for? Seizures. So we have different types of seizures. So we have, what is a seizure? Brief, abnormal, neuronal discharges in the brain. So automatically you would think, okay, I would want a drug that's going to suppress, that's going to quiet the brain, because it sounds like it's too much going on, right? There's too much going on. So we have these transient episodes of excessive, synchronized electrical discharges in the brain. And what's happening in a seizure? Usually, I mean, in the traditional sense, it's that tonic-clonic, everything's moving. You can have the non-tonic-clonic where people are just sort of not moving at all. And these can be occur randomly, but remember, nothing's ever random. It might be random to us because we don't know the reason, but there's always a reason. Always a reason. We may not know why, but it's not, people don't just get sick randomly. Let me just say that. We may not know why, but it's not random. Anyhow, so they can occur randomly, or it can be related to conditions or injuries. So it's interesting because I've had recently a few people that I know call me up and they've had seizures. Mostly, I believe, due to dehydration. Usually that's a big cause. So that would be a related condition. You can also have seizures after an injury. You hit your head, something like that, or sometimes you have a tumor or something in your brain. So anticonvulsants are used to decrease the number or the severity of seizures. So we have seizures, and then we have epilepsy. So epilepsy is 2 or more unprovoked seizures separated by a period of 24 hours. So epilepsy is more of you're having several seizures. So it's a chronic repeated pattern of seizures. So what causes this? Could be genetic. Remember, genetics always that, what are you flipping on? Those epigenetic switches to turn on. Can be infectious. So when people get very sick or febrile, have fevers, they can have seizures. Post-traumatic, neoplastic, meaning maybe there's something on the brain that's causing it. Neurodegenerative. A significant percentage are idiopathic. Idiopathic just means we don't know. We don't know the reason why. A single seizure typically is not treated in the absence of clearly identified pathology. I'd like to believe that, but they usually do. So if you have a seizure and you've never had one before and you had this isolated incident, they generally should not treat you, though every single person I have encountered has been treated with meds with a single, without an identified pathology. A history of 2 or more seizures merits treatment. Okay. I would hope until you found the reason why or did other things to figure it out, like make sure you're hydrated. 60 to 70% of epilepsy patients are seizure-free with pharmacological therapy, and it's the 4th most common neurologic disease. All right, so we've got a couple different types of seizures. You don't have to know all the differences necessarily, but you will have to understand the differences in the seizure and how they're treated, because they can be treated differently. So we have our primary generalized seizures, which are generalized, meaning widespread, so they're kind of all over the body. Then we have our partial seizures, which are focal. So generalized and focal. So our generalized seizure, it's that widespread electrical discharge. So we can have convulsive properties, so that tonic-clonic, and non-convulsive, so like the absence and atonic seizures. And the initial treatment is, of course, prevent injury. We don't want them hurting themselves. Then the partial seizures, which are that focal electrical discharge, so it's just in one portion of the brain. You can have simple and complex. So the simple, you don't lose consciousness, and the complex, you do. So in those focal, again, that electrical discharge is just in one location. So then you can have simple partial seizures. Again, we talked about this, no loss of consciousness, and complex partial seizures, where you do lose consciousness. You can get automatisms, which is that kind of like purposeless movement, but no convulsions. These can progress to generalized seizures. These are often caused by brain lesion, because remember, it's focal, so it's at one portion of your brain. Then the generalized seizure, that widespread electrical discharge, is in both hemispheres. So it's not focal in one part, it's that whole brain. And then we have our convulsive and our non-convulsive. So the convulsive is that typical tonic-clonic seizure where somebody's seizing and moving and they're shaking, prolonged contractions of the extensor muscles with clonic jerking. Then we have our non-convulsive, which is the absence, or what they sometimes call petit mal. These are brief 10 to 20 second losses of consciousness. Sometimes you just see people staring off into space and they're not around. Even though they're not shaking, it's a seizure in the brain. It's that both hemisphere. The myoclonic, so remember, myo is muscle. So it's that sudden shock-like muscle contraction, so myoclonic. And then atonic, so A is not, so no tonic, sudden loss of muscle tone. So these are like the kids that just like fall. They just collapse because they have no muscle tone. They just fall. And so these are the kids that wear the helmets because of falling. So key point with the seizure types is the difference. So partial and generalized. So is it focal or is it both hemispheres? And so even though they can look the same, where you can have either tonic shaking or staring off into space, it's the brain activity that's different. And so again, you don't necessarily have to be an expert in knowing all the different seizures, but you have to understand which seizure is doing what so that you can treat it appropriately. So the drugs that work best for a partial onset seizure are not the same as the ones that work best for the primary generalized seizures. Okay, so let's get into some of these drugs. So anti-epileptic drugs, or AEDs, not to be mistaken for automatic, the defibrillator. So they're anti-epileptic drugs, AEDs. So we have our first generation and our second generation. So these first generations, obviously, were the first ones that came about. The phenytoin or dilantin, you'll see that a lot. Carbamazepine or Tegretol, valproic acid, Depakote. You'll see those a lot. There is a black box warning with these for pancreatitis, aplastic anemia, fetal hepatotoxicity. Nothing to sniff at with those. You have to get baseline liver function tests to test your liver to make sure it can handle these. CBC and monitoring because of that anemia, so measuring those blood levels. Getting a baseline EKG and electrolyte levels. Asians need to get genetic testing because of this rash risk. You never want to stop suddenly, and then the photosensitivity. So these first generation anti-epileptic drugs are used prophylactically for generalized and partial seizures. Usually start with a single drug. The big thing with these seizure meds is you start low and you slowly work your way up until the person can take the least amount to hold off the seizures. So these side effects, sedation, ataxia, dizziness. Think about, okay, it's anticonvulsants are affecting the brain. So anything affecting the brain, and not only affecting the brain, but affecting how it's affecting your body, think about those side effects. So tremors, dizziness, blurred vision, sort of like wobbliness. Again, there's that anemia again. Treat with megaloblastic anemia is a folic acid deficiency. Osteomalacia, so thinning of the bones. There's that pancreatitis again. Stevens-Johnson syndrome. Carbamazepine Tegretol has minimal sedation, but it has cognitive effects. So all of these have their different pluses and minuses that have to be thought about. So with these first generation anti-epileptics, the advantages is that they've been around for a long time. So we know the good, the bad, the ugly, and know what to expect. They also have proven efficacy because people have used them, so they're a little better known on how to use. They're cheap. So people that can't afford to take some of the newer, more expensive medications can do this. And because you do have to monitor serum levels, you also know more that's going on with them. The disadvantages with these first generations is there's more adverse effects. You have to monitor more often to make sure that your liver and your kidneys aren't being destroyed. And there's a lot of drug-drug interactions. And of course, pregnancy, you got to be careful with these. So phenytoin, or Dilantin, specifically, this first generation, what it does is it limits that action potential through the inactivation of those sodium channels. So it's used for partial and generalized seizures, and it comes in IV formulation. So here's some common adverse effects. They're going to be similar, like we just talked about. Cardiac arrhythmias, things like that. There's going to have some drug-drug interactions. Not going to go into specifics with that, just for your knowledge. Then we have carbamazepine Tegretol. So this is limiting the action potentials through inactivation of the sodium channels. Again, partial and generalized seizures. Also can be used for trigeminal neuralgia and bipolar. So it's one of those, secondary uses for this med. Here's the adverse effects again, brain related, small risk of bone marrow suppression, yikes, rash, and then those drug-drug interactions. Valproic acid or Depakote blocks the sodium and the calcium channels, can be used for all seizure types, less effective than carbamazepine for the partial onsets. Here's those adverse effects, similar. This has got those LFTs you got to worry about. Okay, now we've got our second generation. So these are the newer anti-epileptics. So gabapentin, which is gabapentin, lamotrigine or Lamictal, Keppra, this is going to be the main one you see. They put everyone on Keppra, Trileptal and Topamax. So these can be used as an adjunct for partial generalized seizures. These don't require drug level monitoring, which can be a lot easier than having people coming in and getting blood draws all the time. They have much fewer side effects than the first generation. They're generally not better in suppressing the seizures. However, if you can live your life better without side effects, it might be worth it. And the same thing, you don't want to stop suddenly with these. So GABA potentiation, we'll go further into GABA and the psych meds. GABA is a brain neurotransmitter and affects anxiety, but it is a direct binder to GABA receptors, these benzodiazepines. So again, we'll get into this with the anti-anxiety. Same with barbiturates and Topamax. Increased GABA signaling via increased release or decreased reuptake or metabolism. So this is your Lyrica, your Neurontin, So increasing GABA signaling increases inhibitory neurotransmission and calms the brain rather than excites it. So we're trying to calm the brain down, get those signals sort of like, it's the same thing with the heart. When the heart's like, you get AFib, and the heart's quivering because it's so excited. So we're trying to calm everything down. And GABA is the calming, what we want to do. So gabapentin or Neurontin, you might be familiar with gabapentin and Neurontin for, it just left my head. Numbness in the feet. Anyway, it'll come to me. So it potentiates GABA signaling through direct receptor binding. So it's similar to Lyrica, can be used as an adjunct or as monotherapy for the partial onset seizures. So typically used as adjunct due to sedation, tolerance, and abuse potential. So neuropathy, there it is. So gabapentin is usually used for neuropathy. So people who have numbness and tingling in their legs, either through diabetes or some other vascular issues, they use Neurontin. Neurontin can be very habit forming. It gives you kind of a, patients get a little euphoric from it and can be habit forming. So it can be an adjunct. You can use lorazepam or diazepam for status epilepticus, which is that emergency epilepsy. Clonazepam, which is another GABA for absence and myoclonic seizures in children, or difficult to treat seizures. So adverse effects are not terrible. Like I said, it can make you a little tired, it can make you a little loopy, but generally people don't mind that. They feel kind of good on it. Drug-drug interactions, not that many, so it's fairly safe. So it's one of those where it kind of is just like it's like the steroid of the brain drugs. It's like if you don't know what to give them Neurontin and it'll work. They don't really know how, but it does a little something. It doesn't work great, but it does a little something. So with these second generation, these newer anti-epileptics, the advantage is it's for broader spectrum. It works with a lot of different types, less adverse effects and drug-drug interactions, which is great. You don't have to do blood tests as much, and it's potentially safer in pregnancy. Disadvantages is the opposite of that. There's less experience with them. They can be more expensive, and we may not be able to dose them as well. So Keppra. Keppra is the one you're going to see they put everyone on. They don't really know how it works. Maybe this is the steroid of the seizure world. Can be used as monotherapy. This is what they put my friend on. I was like, don't take that stuff. You don't need this. It's also FDA approved for adjunct therapy for partial seizures, primary generalized, and myoclonic. Adverse effects, just makes you drowsy and fatigued. And then we have Vimpat. This is more selective sodium channel. It can be used for mono or adjunct. Similar stuff here. Has some abuse potential, again, for that euphoria. So it's a Schedule 5 drug. Remember the scheduled drugs? You need the special DEA license to, like the opioids, to use. Okay, status epilepticus. What is this? This is continuous tonic-clonic seizures for at least 5 to 10 minutes. Yikes. It's a medical emergency. 20% of patients die. If you have seizures for over 20 minutes, it can cause permanent neurologic injury. So what do we do to treat it? So early in status epilepticus, so less than 20 minutes, you're giving lorazepam or diazepam. Establish status epilepticus, so you're 20 to 40 minutes in, you're giving them phenytoin, phenobarbital, or valproic acid. Refractory status epilepticus, meaning it's been over 40 minutes and nothing's working, then you're given midazolam or propofol and phenobarbital, the big guns. So these anti-epileptics in pregnancy, so the meds can be harmful, but also so can seizures. So you're kind of weighing the pluses and minuses. So of course the meds are preferred over the uncontrolled seizures, which can also cause labor and miscarriage and things like that. So again, always with the seizure medications, starting low and slowly working your way up, so you take the lowest amount of medication possible to get rid of the seizures. So that's the main thing. And then folic acid. Remember, folic acid is being eaten up, so you have to replace with folic acid. Suicidality. So not so much these meds cause suicidality, but just this idea of going into seizures can be really traumatic for people. Never knowing when these can come on. It can be embarrassing, shameful, and scary. So just know that there's a real risk with this suicide in people that have epilepsy. This is from the book. This is just those charts on the different drugs. Febrile seizures. So febrile meaning fever. So fever can induce seizures. Now remember, what do? We treat the cause. So find the cause of the fever and then take measures to control the fever. So giving antipyretics, so something like Tylenol. So, and then for pediatrics, again, they don't recommend use of anti-epileptics for children, hallelujah, and rather just treat the cause, which is the fever. So here's some drugs for absent seizures. The Zerontin, Depakine, Lamictal. Patient education. So making sure they're okay driving, because again, those side effects are the central nervous system. So dizziness, things like that. Reporting side effects to the doctor. That could be problems. Oral hygiene. So sometimes the gums can get irritated. Always taking the medication as prescribed, not skipping doses or stopping. Always making sure not to stop suddenly, which can cause problems. Medic alert tags. So sometimes people aren't allowed to drive. I don't know if I told you the story where I was driving and the car in front of me veered right in front of me, and the person driving had a seizure. It was on the freeway. It was very scary. And that person's license will be pulled. So they'll have to wear a bracelet of some sort just in case something were to happen. Being careful with over-the-counter medications as well. No ingestion of grapefruit juice while on Tegretol, carbamazepine, because it potentiates. Remember, grapefruit juice is one of the most powerful foods you can eat. Grapefruit juice directly affects that same pathway as these drugs. So it's not that grapefruit juice is bad. It's bad if you're taking medications because it competes with it. So drink grapefruit juice. And anticonvulsants can cause birth defects. All right, so now let's switch gears to neurodegenerative diseases. So this is going to be your Parkinson's, your Alzheimer's, Huntington's disease, and ALS. So these are progressive and irreversible neuron loss in specific regions of your brain. Can be associated with abnormal protein accumulation in the brain. We use pharmacologic therapy for symptoms, but not for cures. So anti-Parkinson's drugs. So Parkinson's is a chronic condition. It's characterized by these fine, slow-spreading muscle tremors and rigidity. So it's kind of that, not smooth. They're not able to move smoothly. It's thought to be related to dopamine activity as it relates to acetylcholine. Again, that acetylcholine is diminished, and overactivity of that cholinergic output. Okay, So let's talk some more about this. So chronic neurological disorder, it's that fine, slow spreading muscle tremor, that Parkinson's, everything, you have that shake and they kind of stoop and shuffle. It's not smooth, it's that rigidity and tremor caused by degeneration of those dopaminergic neurons in the substantia nigra, the most common neurodegenerative disease in adults. There is no cure. The goal of treatment is to relieve and slow the progression of symptoms and hopefully keep that mobility. Here's those motor symptoms, that bradykinesia, that slowness of movement. Remember, bradyia is slow, kinesia, movement, so slow movement, but while being rigid. They have that resting tremor in their hand and that shuffling gait. There's also some non-motor symptoms. So this cognitive impairment, they can get a little bit of like Alzheimer's like thinking. They get depressed. They kind of have that like that Eeyore, kind of blah, mood. And then they can get constipated and other things. So dopamine pathways. So here's the different, you don't have to know this, but this is just so you can kind of see in the substantia nigra how the motor control, and then there's some other pathways here that affect memory, and then the hypothalamus to the pituitary, so it can cause some hormonal stuff. And I don't know if you remember me talking about Roundup and glyphosate, the chemical, the pesticide, Roundup, glyphosate, which is in Roundup, and how it particularly affects the substantia nigra. And the other thing that affects the substantia nigra, beets. So remember, these people need beets. It affects directly the substantia nigra and can help with the brain. Okay, so how do we treat drug-wise Parkinson's? Dopamine. So we give them levodopa or carbidopa, which is Sinemet. So levodopa carbidopa is Sinemet. It's a decarboxylase inhibitor. It's an immediate precursor to dopamine, which doesn't cross the blood-brain barrier. So it converts dopamine in the brain by decarboxylases. So carbidopa enhances the effects of levodopa and reduces side effects. So levodopa creates more dopamine in the brain. Carbidopa prevents the breakdown of levodopa in the blood. So the idea is you're kind of using both to increase the dopamine. So it's recommended as the initial drug as well as for long-term treatment. But here's the thing. Response declines after 3 to 5 years of use. So what happens if somebody's young? You got to remember, for Sinemet, this levodopa carbidopa drug, you've got 3 to 5 years. And then after that, it stops working. So it's fine if somebody's older and has 3 to 5 years to live. It's a great initial drug for the rest of their life. But you got to think about if somebody's young. So it can be used as an initial drug just to start them off, and then you stop it, put them on something else, and then you go back to it. Because remember, you got 3 to 5 years total. So how you use those 3 to 5 years, you don't have to use them all at once. But those 3 to 5 years, you can kind of like, you can use it for a year and then something for a couple other years and then use it for another year and then something, So just remember that. Side effects, dyskinesia, which again, we're using the drug for, right? Interesting. Nausea, vomiting, sleep disturbance, psychosis. Not fun. It's contraindications, abrupt discontinuation, because you can get neuroleptic malignant syndrome. Neuroleptic malignant syndrome is that delirium, rigid muscles, fever, and instability. So You don't want to stop abruptly. You've got to wean off of this. Interactions, it's got a few. So dopamine adverse effects, we kind of talked about this, nausea, vomiting. Let's see. Seen in early treatment. Resolves with continued therapy. Loss of effectiveness. So this is going to be the big thing. It has a wearing off effect. So you can do an on-off effect, rapid fluctuation between no effect and increased mobility. So that's the other thing is, again, because we're not all robots, we all metabolize things differently. Some people can have this on-off effect. Treatment strategies for dopamine. You can increase total dosing or dose frequency, use sustained release formulations, supplement with other Parkinson's medications, or give them that drug holiday like I was talking about. Adverse effects, we kind of talked about that already. Now we have dopamine agonists. So these are some of the other ones that can be used when you're not using levodopa, carbidopa. These also have horrible side effects, sleep attacks, yikes. Interacts with CNS depressants like anxiolytics and hypnotics. These are newer dopamine agonists. They can be used alone or with the levodopa. Can be used as initial monotherapy, again, in younger patients. So like I was talking about, you've got that Sinemet for 5 years, 3 to 5 years of use. So when somebody's young, you got to use those other meds in the meantime. So as a levodopa sparing strategy, you can use those other drugs. Has lower risk of dyskinesias and can neuroprotective. I'm not sure, but can be useful as an adjunct for levodopa, so that you can get a lower dose of that levodopa. You can use anticholinergics. Going back, can't forget those anticholinergics. So these are some of those meds. You're familiar with this one, the diphenhydramine, Benadryl. Cogentin is another one that's used often, anticholinergic. So what do these do? These reduce tremors. Can be useful in the early stages of disease and younger patients because it's effective for that tremor. Not as effective for the bradykinesia. Restore balance between the cholinergic and dopaminergic signaling in the basal ganglia. Be careful in older people because of that anticholinergic effect. The dry mouth, dizziness, blurred vision. So, got to think about that. Then there's the MAO-B inhibitors. These are another possible Parkinson's use. These inhibit the breakdown of dopamine and tyramine in the brain, prolongs that levodopa effect. Can be administered early, sometimes used later if the levodopa is worn off. Similar side effects, and there's some contraindications. Then there's the COMT inhibitors, the catechol-methyltransferase inhibitors, so COMTAN. This is remember, whenever you see ACE at the end, that's an enzyme. So this is blocks the enzyme that metabolizes the peripheral levodopa. So it increases the concentration of levodopa and dopamine. Can be combined with the Sinemet, the levodopa carbidopa. Here's the side effects and the interactions. This also has a black box warning. Hepatic injury with this tolcoplamone requires consent, acknowledging of that black box warning. Then we have Symetril. This is actually an antiviral. It stimulates dopamine release. So it blocks dopamine reuptake, meaning the body can use more of it. Blocks cholinergic and glutaminergic receptors. Useful for those dyskinesias. It's typically short-lived, can be used earlier in the course of disease. Efficacy wanes in weeks or months. So again, not so good. And here's a chart from the book on the different Parkinson's drugs and their side effects and notes about that. So as far as teaching, take as prescribed, don't stop all of a sudden. It can take weeks to see effects of these drugs. Be careful with other things that are affecting the central nervous system, like alcohol and other drugs. Careful with driving, can cause dizziness and drowsiness, all that common sense stuff. Be careful standing up. Okay, now restless leg syndrome. How many of you have had restless leg syndrome? I have. And I remember it's very uncomfortable. Happens for me in the evening, and I notice when I'm tired. But I heard all kinds of things about iron deficiency, things like that. Thing that helped me, I don't have it anymore. As you may, surprise, surprise, magnesium. Taking magnesium, no more restless leg. So etiology, it's a sensory motor disorder. It's basically nutrient deficiency. Distressing urge to move the legs, often accompanied by tingling, itching, aching. It's just this needing to move your legs. So there's a medication for that. Mirapex, Requip, Neuropat, Pro Patch. Just take some magnesium. That was the easiest thing. Alzheimer's. So this is the other neuro disease. Alzheimer's is basically dementia. Most common cause of dementia in people. Manifests clinically as a progressive memory loss, senile plaques, tangles. It's an inflammatory response, oxidative injury and free radical formation in the brain, loss of neurons in the cortical and subcortical region. The brain atrophies, it actually shrinks. Neurotransmitters get depleted, especially acetylcholine. Patient responses, again, because we're not all the same, can be idiosyncratic, meaning everyone's a little different. Medications only give a marginal improvement in cognition and functioning, and effectiveness, again, wanes after 1 to 2 years, so even less than the Parkinson's. So we can use cholinesterase inhibitors, so dinazepril, I'm back in the cardiac med. Donepezil, Aricept, and Exelon. So these are acetylcholinesterase inhibitors. So again, ACE meaning enzyme. So it inactivates the cholinesterase, so more acetylcholine is available. So it's symptomatic therapy for mild to moderate Alzheimer's disease. Decreases the rate of cognitive decline, but does not stop or reverse Alzheimer's disease. The memory loss is thought to be from insufficient acetylcholine. Side effects, nausea, vomiting, diarrhea, interactions with other anticholinergics, carbamazepine, these over-the-counter, lots of stuff. So again, here's this parasympathetic, these cholinesterases. Oh, here's back with that urine. Remember, bladder contraction for the parasympathetic, these acetylcholine, what it's doing. So cholinesterase inhibitor mechanism. So we've got to go back to what those do. So it blocks the metabolizing enzyme, allowing for more signaling in those acetylcholine receptors. So Namenda, so it blocks that N-methyl D aspartate receptor ion channel, inhibits that calcium by excessive glutamate signaling. It basically reduces the noise in the brain. Symptom therapy for moderate to severe Alzheimer's. It's usually added on after trying the cholinesterase inhibitors. It's better tolerated with the side effects, less side effects, except for the side effects of aggression. Eesh. Anxiety, confusion, that doesn't sound very good. Other approaches. you know, these brain things, again, back to Roundup and pesticides. These go directly into the brain and affecting the brain. And eating foods that, especially red foods, are good. Supplements like ginkgo biloba, very beneficial. Vitamin E, because again, our brain is made of cholesterol, fat, right? Remember, we needed the lipid soluble to cross the blood-brain barrier because our brain is made of lipids. How many people are on lipid-lowering drugs? When you're on lipid-lowering drugs, it doesn't just get rid of the bad lipids. It gets, just like an antibiotic, it gets rid of all lipids. And our brain is full of lipids. And so sometimes these people where their lipids, their cholesterol is very, very low, it can cause Alzheimer's and brain dementia. So be very careful. Things like the omega-3 fatty acids, vitamin E, these medium chain triglycerides are going to be very beneficial for the brain and keeping the brain working. Epidemiological supports, curcumin, turmeric, polyphenols. So again, colorful fruits and vegetables, that fish oil, avoiding Roundup, anything containing glyphosate, which works on that shikimate pathway. So the shikimate pathway, we don't technically have a shikimate pathway as a human being, as a person, but bacteria do. And what is our body made up of? Bacteria. So when the bacteria are being affected, it affects us. So, and of course, they've got drugs in development for this. So neuropsychiatric symptoms of Alzheimer's, of this dementia, you can get agitation and aggression, delusions, hallucinations, apathy, depression, anxiety, irritability. So you can't really predict how somebody is going to manifest Alzheimer's dementia. Sometimes people are very aggressive, angry. Other people super withdrawn and depressed. Either way, it's you lose your personality. And so it's interesting to think, you know, with these sprays, with these pesticide sprays, killing the color and the flower of plants also affects our personality, our effervescence in a sense. So eating more plants that haven't been sprayed is going to be one of the best medicines, especially considering there is no cure for these. And even with taking these medications, it really doesn't do much, to be honest. Atypical antipsychotics, which we will get into in the psych lecture. There's some efficacy for aggressive and psychotic behaviors. But again, those have lots of side effects, black box warnings, and again, you're just throwing on more meds and side effects. So this is from the book with the medications, side effects, things like that. And that's it for that lecture. All right, aloha.